cakes out there as well. And our first presenter is Christine and Kevin. We need to do something special to turn this TV.
Do you need my help?
I do.
How do you hear the band? Nothing. There you go.
There it is.
April
I can't handle the pressure. Everybody needs to keep their eyes on John Marola.
Yes.
He's the trickster on April Fool's Day.
Yeah.
So my name is Christine Sweeney, and my topic is congestive heart failure. So pathology, pathophysiology of congestive heart failure is just basically that the body can't pump the blood throughout, the heart can't pump the blood throughout the body as effectively as it used to. So that can be, that can cause the kidneys to retain water and fluid in the body, which will be important to our case study as we go on. But it can be divided into systolic or diastolic heart failures. So systolic is reduced ability to contract, and diastolic heart failure is that it has a hard time releasing either because the muscles are too thick or because they're stiff, they're impaired in that way. So the most common cause of heart failure is left side heart failure, systolic, again, which will be important in our case study. But this is an example showing that the thick muscles in the diastolic and the thin, weak heart muscles that can't pump the blood throughout the body very well. So prevalence and risk factors, it's very common, mostly seen in older adults, older population. It affects about 2% of the population in America. And risk factors are basically anything that can harm the heart muscle. So things like hypertension, coronary artery disease, cardiomyopathy, heart attack, diabetes, use of cardiotoxins, and obesity. So signs and symptoms of congestive heart failure, there may or may not be any signs or symptoms of congestive heart failure, but a lot of times fluid buildup in the lungs or throughout the body, which is the kidney's response to congestive heart failure, which can cause dizziness, fatigue, weakness, or rapid or irregular heartbeat because the heart has a hard time working how it should. So medical nutrition therapy for congestive heart failure is trying to limit the sodium in our diet, and that's to help reduce the fluid retention and heart healthy, so good for our hearts. Monitor your weight to see about that edema or fluid retention, possible fluid restriction, monitoring heart pressure, a combination of medications. A lot of times patients are on beta blockers, ACE inhibitors, or diuretics if they have congestive heart failure. Stopping smoking, if you're able to do any exercise, small amount of exercise is good for heart failure. Possible weight loss, and those are the medications that a lot of times congestive heart failure patients are on. So coding and reimbursement, the ICD-9 code 428 is for congestive heart failure. And then this is one of the diseases that can have a penalty if they're sent back to the hospital within 30 days and that's the diagnosis. Or they just don't reimburse. But our patient actually, his diagnosis code is for acute kidney injury, so that's the ICD-9 code 5. So, looking at our patient, Mr. K is his name. He's a white male, 75 years old. His usual body weight is 209 pounds, which again is relevant. His height is about 67 inches. He lives at home. He's married, lives with his wife in a 2-story home. He's a high fall risk. He's retired. He's now using a walker. He was using a cane prior to admission. He has family history of heart problems, no drug or alcohol use, smoked in the 60s, and he has allergies to NSAID, which is an antibiotic, and ACE inhibitors. So he just follows a regular diet. He's diabetic. He doesn't watch his carbohydrates very strictly, doesn't really follow portions all that well. His wife prepares most of the meals. He has a typical breakfast, coffee, toast, cereal, maybe a sandwich for lunch. His main meal is dinner, so just typical meat, starch, vegetable for dinner, and he snacks throughout the day. He has snacks. So his current medical and surgical conditions, he had recent lumbar surgery for his back. He was in Health South with a wound vac and taking antibiotics, which they found out he's allergic to, so that was one of the allergies we mentioned earlier. He had a rash all over his body and developed an antibiotic resistant infection, so that got him moved to Presbyterian Senior Care. He also has diabetes, congestive heart failure, hypotension, acute kidney injury, and edema are the main things we're going to look at for him. He's had an extensive surgical history, a lot of heart surgeries, also knee, carpal tunnel, shoulder surgery, and drainage as well. So he's an extensive medical history. The main things we're going to try to look at are the heart medical history, so the congestive heart failure. The MRSA is kind of why he started at Presbyterian Senior Care. The peripheral vascular disease, the dysrhythmias, coronary artery disease, COPD. He actually has that, so that makes it harder for him to breathe when he gets the severe edema later, which I'll talk about. The low back pain, which is why he had the surgery in the first place. GERD, hypertension, type 2 diabetes. He has asthma. He just has a lot going on. So he's also on a lot of medications for his extensive medical history, but the main ones are the Bumex and the Metoclopramide, which is a beta blocker. He's not on any ACE inhibitors because he's allergic to those. So his chronic disease risk is very high. He has multiple chronic diseases, diabetes, the heart failure, COPD. His current diagnosis is actually the acute kidney injury though, and hypotension, which later goes to the hospital. So this is his story. He started at St. Margaret's for the surgery. As I mentioned, he had the antibiotic-resistant infection, which took him to Presbyterian Senior Care on the 15th of October because of the infection, and he was too weak to return home since he does live in a two-story home. While he was at Presbyterian Senior Care, he ended up having a hospital admission because of hypotension. He had a blood pressure of 64 over 42, which is very low. So he was shaking and shivering. While he was at the hospital, he had a renal consult. His creatinine level was 2.0, and over the past month it's been 0.8 to 1.5. They put his diuretic on hold. He doesn't have any proteinuria. He comes back to Presbyterian Senior Care with the diagnosis of the acute kidney injury, which is the coding I told you about earlier, and the hypotension. And he's actually been gaining weight up to 40 pounds in the last month from fluid retention. So that's why the usual body weight of 209 is so relevant. So this is his history of the edema. Again, he comes to Presbyterian Senior Care on the 15th of October. He starts on the Bumex to wrap both of his legs because it's in his lower extremities. He gets weighed weekly. He has 2 to 3 plus pitting edema, and he weighs 223 pounds at this point. So as we go on, they put him on a healthy diet, trying to limit the sodium, limit the fluids. He ends up with 4 plus pitting edema, and they notify the doctor. So they increase his Bumex, and his weight continues to increase, though he's up to 244 pounds. They continue to weigh him, and he continues to have the edema. The 26th is when he goes to the hospital, and they put the diuretic on hold. So he comes back, I believe it was maybe the 30th of October, and he comes back, and on the 3rd, he's still on the Bumex. They started it again, but his weight is up to 253 pounds. So he's gained over 40 pounds of fluids from this edema. They increase the Bumex, they continue to increase the Bumex, and he starts going down in his weight. So he's ridding his body of the fluids. The edema is significantly improved. He refuses to wear the ACE wraps anymore because he does not feel he needs them anymore. And when he's finally discharged on the 18th, he's back down to the 200 pounds, which is closer to his usual body weight. So he has a significant weight from this edema throughout his admission. So looking at his lab values from when he started to when he ends, the main ones, I looked at the A1C. He's not the best controlled diabetic, which we already saw from his diet recall. His bun is elevated and his creatinine are elevated, which
The A1C, we can't
8.0. 8, it's over at the top
8.
there. Yeah, 8. creatinine are elevated, which can show kidney failure, kidney problems. The rest of his labs, he has anemia from the rest of them, and then he has a lot of fluid retention at this point, which could be part of the reason why some of those labs are a little bit lower as well. So on the 17th, his creatinine is still high, and his globular filtration rate is low. So again, that's showing the kidney failure that is progressing with that, and he still has the anemia as well. So the nutrition care process, the PES statement I found is the involuntary weight gain related to the current medical condition, the edema from the current medical condition from the kidney failure and the congestive heart failure, as evidenced by the 4+ bilateral pitting edema, but I also could have put from the greater than 40 pounds of weight gain. So his nutrition intervention is encouraging a heart-healthy diet, low in sodium, possible fluid restriction, monitoring his weight and his edema as he goes home and throughout his stay. And his discharge instructions are continue on the Bumex, wrap the legs in the ACE wraps. I don't know how well he'll follow that since he doesn't seem that he needs that. But elevate his legs and continue to follow the heart-healthy, low-sodium diet when he's at home. Any questions?
I have a couple if I may.
Okay.
We have to address, well, the life cycle, so A and D can see that we've done, we looked at nutrition through the life cycle. Is this a disease that you see very often in children or young adults?
I would say no. I think it's more common in older adults, mostly because there's damage to the heart. So I guess it could be in children or young adults, but
they
probably
have to
after
have
something.
Have to be a serious heart problem.
Yes.
Okay, what do you think made the BUN and creatinine go up? What kind of medication did he get that's really hard on the kidneys?
The Bumex, the diuretic.
Well, that's somewhat, but there's something Stephen usually tells us. If you see a BUN go up and a creatinine on a patient with an infection, that's a key now, with infection, what should you look at?
The antibiotic. So
That
he had
would
the IV antibiotic when he first went to Presbyterian Senior Care because of that allergic reaction. So.
Okay, and the last one, there's another medication that oftentimes people with CHF is on. I didn't see it there.
The ACE inhibitor.
No,
Is that what you mean?
another one there.
The beta blocker.
No. He was on the beta blocker, right?
He was on the diuretic and the beta blocker.
Okay, the blood needs to be pumped, okay, and it's kind of sticky and kind of thick.
Is it a thinner? A blood
Yes.
thinner? I didn't see him on that. He was on a
Now, he may
statin.
not have been on it, but that's one that you usually look for, because a lot of times they're on one of the blood thinners, because it makes it, why would they order the blood thinner for it?
Just to make it easier for the heart to pump it.
Yes.
The beta blocker kind of dilate the vessels too a
Yes.
little bit. That
Yes.
makes it
But
easier.
the two work in different things, so a lot of times you'll see them on both. Nice job.
Yes.
Can everybody pass your evaluations for Christine into the? Thanks. Just when you're done, leave them at the end of your row. Sorry, that's okay.
Too much what? Stuff?
Oh, yeah.
Let me get one, it's just the things that we should take off.
This one? Yeah, there you go. No, I can't see it. You should be able to see it. Can you help? To this side. I can dance.
Still one more.
Okay. Okay, I know we're still waiting on a few evaluations, but whenever you're done, you could just put them to the center end of your row and I'll get them whenever I'm done with mine. Okay, so my name is Marilee Fritsch and my formal case study was on head and neck cancer. So Linda's in here, so I figured she would really like this slide because it talks about famous people with this condition. So, does anybody know which famous baseball player had nasopharyngeal carcinoma? Does anybody know this one?
No.
Any guesses?
Yeah.
Babe Ruth. Okay, so the next one is this U.S. president was the only president to die of cancer. He was diagnosed with a carcinoma of the right tonsillar pillar.
I
You don't know these?
don't know.
I'm surprised. This is Ulysses S. Grant. And then the last one, this famous psychologist developed cancer of the jaw. This is probably like the one psychologist that everybody has heard of. Freud, yes. And I just wanted to note that both Babe Ruth and Sigmund Freud really liked their cigarettes, and Ulysses S. Grant liked his cigars. So that may have something to do with the fact that they developed this type of cancer. Okay, so this is just a picture of the different regions for head and neck cancer. At first, I was kind of like, okay, head and neck cancer, what does that even mean? I figured maybe it would include part of the brain, but I guess brain cancer is an entirely different thing. So it's talking more about like the nasal cavity in your mouth and the beginning part of the GI tract. So you can see here, there's the tongue. I got to see 3 patients with head and neck cancer, but there was only one that I actually looked in their chart and found all of the information on that I'll be presenting on. But I met a woman and she had cancer, I think like in her jaw somewhere, and she got radiation, so she ended up losing all of her teeth and became edentulous just from all of the radiation. And another person I saw, he was also edentulous and he kind of had like a cleft lip after his surgery. So there were a lot of interesting things to pay attention to with feeding patients who have had head and neck cancer. So through the life cycle, I just started off with cancer. So childhood cancer is the second cause of death of children over 5. The first cause of death is just pure accidents. So head and neck cancers in children represent 12% of all childhood malignancies. So out of all the childhood cancer that you hear about 12% of it is head and neck cancers. And this is just a list of some examples of childhood cancers that present in the head and neck. Okay, so through the life cycle, pediatric Hodgkin's lymphoma occurs in about 1,000 cases per year in the U.S., and the majority of those affected are adolescents. So this type of cancer presents more in the older children and adolescents. And finally, rhabdomyosarcoma is the second most common soft tissue sarcoma in children and adolescents, and about 1/3 of those present in the head and neck region. Okay, so some risk factors that I wanted to note here. Smoking is the first thing that always came up when I did any type of research on risk factors for head and neck cancer. Chewing tobacco is also another one. Some HPVs can lead to head and neck cancer. I bolded industrial exposure because that's really important to the case that we'll be looking at, because my patient worked in the steel mills. So I feel like that had a lot to do with the development of his disease. Chronic GERD, asbestos exposure, it's more common in African Americans, twice as more common in men than in women, and if you're over the age of 50, you're more likely to develop head and neck cancer. And of course, fruit and vegetable consumption is good for preventing all types of cancer. And then there's the Epstein-Barr virus, consumption of mate, which is a South American drink. If you consume a lot of that, you can increase your risk of developing head and neck cancer. And the last thing, this wasn't noted in all of the sources that I found, but it was mentioned, and I didn't know what it was, so I looked it up. And it's just white spots on the tongue. And I guess if you get those a lot, or if you have them for a long period of time, they can become cancerous. And that happens to about 1/3 of people with leukoplakia. So these are just some of the ICD-9 and ICD-10 codes for coding and reimbursement. The patient that I had, his diagnosis was just malignant neoplasm of the head, face, and neck, so it was a very broad diagnosis. So my patient was Mr. L. He was 70 years old. He was at Presbyterian Senior Care for physical therapy and occupational therapy. He was born and raised in Verona, so he lives very close to here. He lives alone, and he had a son who lived next door. He worked in the mills, like I said before, and this was just the income that I found for the most recent data that I could find. I don't know when exactly it was that he worked in the mills. I didn't have the opportunity to go and speak with him because he was only there for a short period of time, but this is pretty much the range of the income. He was Methodist. He stated that he was a non-smoker, non-drinker. His speech was soft and understandable. He had a tumor underneath his tongue, so that may have played a role in his speech. And like I said, he was at Presbyterian Senior Care for PT and OT. He had positive bowel sounds, non-tender abdomen, and he made bowel movements, so his gut was pretty intact and it was doing what it should have been doing. So his medical and surgical history, I just bolded some of the things that are kind of nutrition related. So he did have a tumor under his tongue, he had dysphagia, and he had a hemorrhage of his GI tract. And later in the notes I found that he had coffee ground emesis, so that would also indicate that he had a hemorrhage of the GI tract. He was allergic to chocolate, unfortunately, poor guy. He was on some medications. There were some for CHF because he did have that, and he was also on a blood thinner and of course morphine for the pain. So the goal for nutrition therapy for any type of cancer is to provide enough calories and protein to prevent weight loss, to regain strength, and to rebuild healthy tissues. So these are some of the nutritional considerations for somebody with cancer, especially of the head, face, and neck region. Xerostomia, or dry mouth, is something very pertinent to them. And I don't know if he experienced it that much, but I know the one patient that I saw at Armstrong Center for Medicine, and how she had cancer, and one of her biggest complaints was that she doesn't make any saliva anymore. And so that certainly affects the things that she can and cannot eat. Sore mouth and sore throat, that's especially true if they have any type of radiation. Difficulty chewing, kind of like the same themes that we were talking about before, and of course ways to do that is to modify your diet consistency, so that's really important in these patients. Dysgeusia is another thing, so they have altered sense of tastes. So some things that used to taste good to them may not taste good anymore, so it's kind of, having a really big effect on the things that they can and cannot eat. And it probably has a lot of psychological effects as well, because there are certain things that they used to like to eat that no longer taste good. Nausea and vomiting is another one, poor appetite, and the big thing for those is encouraging high calorie, high protein snacks to just have on hand. Okay, so the assessment of my patient, unfortunately, like I said before, I was unable to obtain, so I obtained this information from the chart. I was unable to obtain information from speaking to my patient, so I mistyped that. But he was 70 inches tall, 120 pounds, his BMI was 17.36, so he was an underweight guy. If you do the protein needs for a gram per kilogram body weight, which is what the dietitians did, you would need 55 grams of protein a day. Energy needs, I kind of played around with this a little bit, and I finally set it on 28 kilograms per kilogram body weight because he needed a little bit more because he is underweight. And I did his fluid needs as 1 milliliter per kilocalorie, so that's about 2,200 milliliters of fluid. He was on Jevi at 1.2 kcals at 75 cc's per hour, so over the course of a day he would get 2,160 calories. These are some of the pertinent labs. I think somewhere in the charts it noted that he had a history of anemia, so his hemoglobin was low. His glucose was a little high, but that wasn't really the biggest concern at that time. So physical condition, he did have a stage 1 area on his coccyx, so there was just a little bit of redness there. Nothing that would really increase the protein needs. His speech was soft but understandable, and that was probably because of the tumor he had on his tongue. He was experiencing some fatigue, and like I said earlier, at one point, he had a bout of coffee ground emesis, and I think that's what actually sent him out and back to the hospital. He also had some dry, flaky skin, and that can be indicative of his fluid status, his fluid balance, whether he was hydrated or not, or it could also just reflect the way his skin reacts to the type of air that's in the room, whether it was dry or not. And he was also under no respiratory distress, so that was a good thing. So he had a lot going on. So his diagnostic statement that I chose for him was inadequate oral intake related to his NPO status, as evidenced by being on Jevi at 75 cc's per hour, and I also noted his BMI of 17. Because I couldn't meet him, I couldn't really tell if it was really likely that he would be able to eat again, but I still just included this because maybe it would have something, to do with his weight at this point. So for my intervention plan, my goal, this may or may not be like wishful thinking, but I really wanted him to be able to be back to PO status by discharge. I wasn't able to see if he was. I know that he went to the hospital, but I don't know if he went back to the facility or what the steps were after that. So just assuming that he were still in the facility, my plan would be to monitor his diet tolerance and progression if his diet was going to progress about every 3 days, just so I could see how he was tolerating it. So for monitoring and evaluation, I'd want to know, is he still on tube feedings? Has he gained any weight? Has he lost any weight? Is his weight stable? How is he tolerating the tube feedings? Is there any nausea, vomiting, or diarrhea? How is he managing his dysphagia? Has he tried eating foods yet? Has he been approved to eat foods yet? Has the appropriate diet consistency been ordered for the time that he is able to start eating again? And of course, the dietitian would want to work in conjunction with the doctor in speech to determine what foods he is able to eat and when he is able to eat these certain foods. So these are just some resources for head and neck cancer. The first one is it's kind of for the general public, but I think it's really good for health professionals too. It kind of lays it all out there, the basic things you need to know, and it goes a little bit in depth. And then the next one is an article from today's dietitian, and it relates to nutrition status of the head and neck cancer patient. It's from June 2008, but I feel like it would still be relevant and really helpful to us just to understand the condition and understand appropriate feedings for that. And then these are the references I used. Does anybody have any questions?
Surprisingly, I do.
Oh, yes.
Was he on any medications? Did I miss that? Or I didn't see it. He was.
Yes, I have his medications up here. They are.
I didn't see it on
He was on levothyroxine for hypothyroidism, enalapril for CHF Prevacid. He was on a multivitamin. He was on low pressor, heparin, and morphine.
Do you have an idea of what might have contributed to the coffee ground emesis?
Yeah, his GI bleed. That's what my guess would have
Right,
been.
but what caused the GI bleed? Do you have any idea what may have caused it?
Possibly one of the medications, the blood thinner.
The blood thinner, very good thought. What's the other thing that could possibly do it? Not as likely as the blood thinner. What's another thing that could cause it? Not a medication, but something else within your realm.
GERD? No.
Where's he getting his nutrition?
Yes,
Where? How?
through a tube.
Okay, does he have any time off, or is there something going in all the time?
There's something going in all the time.
Could that contribute to it? Sure, because he's stimulating to produce
Okay.
hydrochloric acid all
And
the
he's doing
time.
it all the time, right? Okay.
But more than likely, he's probably,
Yeah, that would be my guess.
he's on heparin, huh?
Mhm.
Not a very common one, but it's because he was in a facility, I guess. He probably will not go in.
Okay. Christine.
This is Julia. Is this for Christine?
Okay, I'll go ahead and get started. My name is Mallory Pavlonis. My case study is on protein, energy, malnutrition, so hopefully you learn a little bit. So just a quick outline of things I'm going to cover. A background of protein, energy, malnutrition, the pathophysiology and causes, medical nutrition therapy and interventions to treat it, coding and reimbursement, and then I'm going to go over my case and my patient overview. So what is protein, energy, malnutrition, or PEM? It's defined by the Academy and IDNT as inadequate intake of protein and or energy over prolonged periods of time resulting in loss of fat stores and or muscle stores, including starvation-related malnutrition, chronic disease, and acute disease. So just to clarify, malnutrition can obviously occur at any point throughout the lifespan. I feel that it's seen more in younger kids and the elderly, not so much in the middle, but it is possible and it can really occur to anyone. And also, before anyone asks me the question, it can occur in the obese and overweight population. It's just a lot harder to diagnose, and you have to rely a lot more on the report from the patient and what they're saying about their weight loss. If they feel that they're having strength reduction and muscle wasting. But it is more common for them to have micronutrient malnutrition rather than macronutrient. So I'm going to really focus more today on the macronutrient malnutrition. So obviously malnutrition is something that wants to be avoided because it can lead to an increased risk of pressure ulcers, impaired wound healing, immune suppression. It increases infection rates, fall risk, and loss of function. So we obviously really want to avoid that. So there are a variety of causes behind malnutrition. It's different in every case, pretty much. So starvation-related malnutrition is the classic type of malnutrition that everyone pictures in their head. And this would be like a primary diagnosis. So this would be something from anorexia or an economic condition that would lead to a decrease in food availability or food intake. Chronic disease-related malnutrition could be related to an outlying factor like cystic fibrosis, COPD, chronic kidney disease, CHF, cancer, inflammatory bowel disease, things that have kind of been going on for a while that could lead to malnutrition. And acute disease or injury-related malnutrition, so this includes major infection, burn, trauma, closed head injury. But like I said, any of these can occur at any age. And the chronic disease and acute disease malnutrition would be a secondary diagnosis, and the chronic disease or acute disease would obviously be the primary diagnosis in that case. And all the diseases that I mentioned, like anorexia, CHF, COPD, major infection, burns, those are all risk factors for malnutrition. So if someone does have one of these conditions, they want to be screened and watched closely to prevent malnutrition or catch it in the beginning to avoid it. So marasmus and kwashiorkor are two main types of malnutrition that I feel a lot of people have heard about. So marasmus is a decreased energy intake, while kwashiorkor is just a decrease in protein intake. So there is some differences between the two that is shown in this list. Marasmus, it takes a while to develop, while kwashiorkor is just in a couple weeks. Different symptoms and clinical features, different lab findings, and the mortality rate is a little bit different. And I have a slightly alarming picture next, so if you're sensitive, just don't look. I just wanted to bring it up. So these pictures showcase the difference between marasmus and kwashiorkor. So marasmus, like I said, is what you picture someone that is malnourished to look like. While kwashiorkor, this little boy looks like he's malnourished, but if you look closer, you can see the edema in his stomach and feet, which is a result from the protein malnutrition. So how is malnutrition diagnosed? In the past, it was different than how it is diagnosed now. In the past, it was diagnosed by looking at albumin, pre-albumin, and classified mild, moderate, severe based on these lab findings. And now it's more based on nutrition assessment, physical findings. So what kind of changed here is serum albumin and pre-albumin are negative acute phase react. It has a negative reaction. So these albumin and pre-albumin will decrease in response to any inflammation. So if someone's in just for a simple surgery or like a knee replacement, this will affect their albumin and pre-albumin, but doesn't necessarily mean that they're malnourished. So studies have found that this might not be as accurate as we once thought it to be. So now we're looking more at energy intake, interpretation of weight loss, loss of body fat and muscle mass, fluid accumulation, and reduced grip strength. So like I said, diagnosing malnutrition is more based on a nutrition-focused physical assessment. So this identifies loss of body fat or muscle mass, looks at fluid accumulation, and grip strength. And in the handout, I included a malnutrition matrix, which was given to me during my clinical rotation, which kind of shows you how they gauge if it's moderate or severe, and the different ways or different things to look at to diagnose malnutrition. And it actually says at the bottom in one of the notes not to use albumin and pre-albumin because recent evidence shows that they don't really change. So medical nutrition therapy and interventions for protein energy malnutrition, it basically depends on what is causing the malnutrition. So if malnutrition is the secondary diagnosis, they're going to treat it mainly by treating their primary diagnosis. So this includes if they have cancer, they're going to treat the cancer and eventually get to the malnutrition through treating the cancer. But if it is the starvation, they obviously want to feed the person, taking caution for refeeding syndrome and things like that. So there's 4 different interventions really: food and or nutrient delivery, nutrition education, nutrition counseling, and coordination of nutrition care. So hopefully in someone that is experiencing malnutrition, if you cover all these, then hopefully that would help. And just some more specific interventions: adding food or snack to help them gain weight, removing any diet restrictions like a low sodium or diabetic diet, just to help them get as much food in them as they can. Fortified foods, nutrition supplements like Ensure, Boost, adaptive feeding equipment if they're having trouble feeding themselves. And obviously, if they don't have access to food, referring them to things like the food bank and other resources that might be helpful for them. So when looking into coding and reimbursement for malnutrition, there's quite a few different codes. Malnutrition is actually one of the nutrition diagnoses with the highest reimbursement rate. So the hospital often gets the most money from this nutrition diagnosis. Because malnutrition leads to increased length of stay and other factors like pressure ulcers, infection, things that cost more money. And as you can see here, the descriptions for some of these codes are based on albumin and pre-albumin and things like that. So the codes have not been updated since the new malnutrition criteria has been established, but it's something that is in the works to be updated from what I saw. Okay, so on to my patient review. So my patient was my main source of information along with her medical records. Luckily, she was a pleasant lady. I had to go through a couple different patients that were miserable and grumpy and wanted nothing to do with me, which I don't blame them because they're pretty sick. So Mrs. C was pretty big. So she is a 66-year-old white female, 5 foot, weighed 71 pounds. Her ideal body weight for her height was 100 pounds plus or minus 10 pounds. So she is 71% of her ideal body weight. Her usual body weight was 136 pounds. This was about 3 to 4 years ago. So she had a 52% change in her usual body weight, which is a pretty big chunk. And her BMI is 13.9, a very little lady. She has a pretty extensive medical history, breast cancer, cervical cancer, hypertension. She has hepatitis B since 2011, has scoliosis, had a kidney stone. One thing I want to point out here, bowel resection, and then a few other things. And her family history is, she does have a family history of cancer, stroke, heart attack, hypertension, pretty much everything that she has also ran in her family. So medication she was on at home and the diet she was on at home, mainly to treat the hepatitis C, her liver problems, for her hypertension, blood pressure, cholesterol, things like that. In her diet history, she was trying to do high calorie, high complex carbohydrate, just to try and fix her malnutrition and get a lot in her. And she was following a low oxalate diet, and she said that someone told her when she had her kidney stones in the past to try and do that, so that's her explanation she gave to me for following that. And her appetite was fair before she came in. Her social history, she's an active smoker, 3 to 4 cigarettes a day for 50 years, so she was being treated for COPD in the hospital with medication. She no longer drank alcohol, she quit 4 years ago, but used to drink socially. No illegal drug use, she lives by herself, is divorced with 3 kids, and previously worked as a front desk clerk, but is receiving disability now. So it's pretty routine to do a nutrition screening, and the whole purpose of a nutrition screening is to screen for malnutrition. So whenever I was screening her, she did have an unplanned weight loss of greater than 10 pounds in 3 months. She had decreased PO intake and appetite. And obviously her weight was inappropriate for her height and age. She required TPN, and she had the diagnosis of failure to thrive and malnutrition. So in the hospital, she was again on a high-calorie diet, receiving 6 small meals, so breakfast, lunch, dinner, plus many snacks in between. She was receiving Ensure with all her meals and for snacks. And they were keeping her on that low oxalate diet just because that's what she wanted. And she said again, her appetite ranged from fair to poor. And just a reminder of her anthropometrics here. medication she was receiving in the hospital for blood pressure, cholesterol, IBS, an ACE inhibitor, one to control stomach acid, one for pain, her hepatitis B medication, and Spiriva, which is to treat sleep. Physical findings, she had an obvious subcutaneous fat loss and muscle mass loss. She had temporal wasting, prominent clavicles and scapula, no muscle on her arms or her calves. She looked very, very, very thin, very sick, and malnourished. She did have trace edema in her bilateral lower extremities. And her skin was intact, so that was something she had going for her. And I did do a nutrition-focused physical assessment with her, which is how I kind of concluded all the muscle mass loss. So for her PS statement, I obviously used a nutrition diagnosis of malnutrition related to chronic illness. I kind of associated it with the bowel resection, the COPD, the hepatitis, kind of just everything combined that she had going on. As evidenced by decreased energy intake, weight loss, 53% of her usual body weight, fat and muscle wasting, and fluid accumulation. So what was the plan for her? Obviously to gain weight. The patient would ideally like to weigh 120 pounds. So she was previously being seen by the nutrition support physician at Allegheny General and was admitted to the hospital because they had already established that she was malnourished. She was admitted to get a port for TPN, so that's whenever I met her. So that was obviously an intervention to help her gain weight. So she received, she was receiving TPN in addition to her regular diet with high-calorie and protein supplements. So she continued to eat by mouth, in addition to her Ensures and things like that. Her TPN was only about half of her nutrition needs, 935 calories. And things to monitor and evaluate, obviously, how much she's eating, how she's doing with the TPN, and how she's tolerating it. Her weekly weights just to track her weight gain. We want to monitor her labs. It's important to look at her electrolytes, liver function, things that you monitor when receiving TPN, just to avoid refeeding syndrome and take that into consideration. And we were going to evaluate her progress to determine the length of how long she needed to receive TPN. So I did not get to see how long she was on TPN since she was only in quickly for her TPN port, but that was something that was going to be followed up with the nutrition support physician, depending on how well she was gaining weight. Does anyone have any questions?
Do you guys have any? Did I get that?
So my name is Erica, and I acquired a patient with gastroesophageal reflux disease for my formal case study. And this disease is more commonly known by its acronym GERD, so I'll probably refer to that for the rest of the presentation. So what is GERD? It's defined as a condition in which acid from the stomach or even the duodenal area right after the stomach flows back up into the esophagus, causing discomfort and in some instances damaging the esophageal lining. So the etiology of this disease is both physical and it has a lot to do with lifestyle factors. So the risk factors for the disease, it's mainly attributed to the incompetence of the lower esophageal sphincter. And the LES, which is the lower esophageal sphincter, is lowered by increased secretion of hormones. And these hormones can be gastrin, estrogen, or progesterone. And that's why sometimes often in pregnancy, with the increase in progesterone through the body, women complain a lot of heartburn or they suffer from gastroesophageal reflux disease during that time. And it can also, this pressure can be lowered by the presence of other medical conditions, such as scleroderma, where there's a hardening of the soft tissues in the body, or a hiatal hernia. And then also smoking cigarettes, it lowers the pressure of the lower esophageal sphincter muscles. And obesity, the extra weight on the abdomen, it causes pressure and can lead to GERD. And the use of certain medications. These medications, some of examples that may lower this pressure are dopamine, morphine, and theophylline. And then also specific foods can lead to the lowering of the pressure, which can lead to the reflux of the stomach acid. And I'll later delve into the specific foods on a later slide. So the occurrence of GERD, it's pretty prevalent. Each year, more than 20 million people in the U.S. suffer from symptoms of GERD daily, and more than 100 million suffer occasional symptoms. So that's about 10 to 20% of adults in the U.S. that suffer from GERD. And it also frequently occurs in infants, typically beginning at birth. Normal physiology of the stomach and the muscles around the lower esophageal sphincter. The LES, it's a bundle of muscles at the base of the esophagus where it meets the stomach, and it prevents acid typically from being able to come back up into the esophagus. And they're not under voluntary control. And under normal conditions, the atmospheric pressure within the esophagus is greater. It has to be greater than that of the stomach in order for it to prevent the gastric or duodenal contents from refluxing. So normally, the esophagus is at a negative pressure, whereas the stomach is at a positive pressure. So these factors definitely increase the predisposition of reflux if it's the opposite. So for the pathophysiology of the disease, the lower esophageal sphincter relaxes abnormally, or those muscles within the lower esophageal sphincter have weakened. The pressure gradient is altered between the esophagus and stomach, as I had mentioned, from the normal physiology. And then that leads to gastric contents refluxing into the esophagus. So if this continues for a long period of time, it can cause other complications such as esophagitis, bleeding, esophageal narrowing or strictures, and Barrett's esophagus, which is a precancerous condition. So in diagnosing GERD, patients who are diagnosed should be considered at a potential nutritional risk for various different reasons. So because of the symptoms of the disease, the constant acid going back up into the esophagus can cause, as I said, strictures or bleeding or irritation. And then drug-nutrient interactions, I'll talk a little bit more about that on another slide. But the medications that are prescribed for GERD can cause a decreased absorption of certain nutrients in foods, and then potential decreased oral intake. So if you have constant reflux, if you feel the symptoms of heartburn, you may feel fuller faster, you may not be able to consume very much food in one sitting, you have discomfort, so that leads to potential decreased intake. So some nutritional indicators of this would then be weight loss, dysphagia, vomiting, impaired oral intake, a limited food variety if certain foods irritate the stomach or the esophagus for the patient, they'll stay away from certain foods. Iron deficiency anemia can also be a nutritional indicator for the disease, and impaired nutrient absorption from medication use, as I had mentioned before. And then also obesity is a nutritional indicator for the disease. So some signs and symptoms of GERD this is obviously attributed to the acid refluxing into the esophagus and from the gastric acid and pepsin that are released in the stomach. And so the reflux may also occur during lower esophageal sphincter relaxations, which are periods that occur outside of swallowing, and they may be stimulated by the presence of food in the stomach after a meal. So the symptoms of GERD may include dysphagia, heartburn, increased salivation sometimes, and belching. But there are a lot of people that actually are unaware that they have GERD, and they don't always exhibit signs and symptoms such as heartburn. So complications of GERD. Untreated GERD can lead to the following, as I have stated already: dysphagia, and that dysphagia can then lead to aspiration, and respiratory conditions, pneumonia or asthma can be a complication, ulcerations within the esophagus, perforations or strictures, and then Barrett's esophagus, and inadequate nutritional intake. Electrolyte balances can also occur from vomiting or and then iron deficiency anemia can occur secondary to the blood loss or decreased absorption of iron from foods because of medication use. And then B12 and calcium absorption can be decreased as well for the same reason, medication use decreasing absorption by not allowing the stomach acid to fully break down the nutrients for those to be absorbed. So through the lifestyle, GERD is diagnosed pretty commonly in infants, and I found that especially preterm infants develop gastroesophageal reflux. At that point, it's not considered a disease. In infancy, that's not the term that it's referred to when it's diagnosed. But a lot of times, because of the infant's organs not maybe being fully developed, the stomach and esophagus are one of the later ones to fully develop. So if they're preterm, a lot of times reflux does occur commonly in infancy, and it can manifest itself as wet burps after feeding, and then even certain behaviors of or things that the parents are doing can oftentimes lead to gastroesophageal reflux in infants as well, such as not cradling the baby when feeding. If they're sitting them, kind of propping them up on a pillow, them sitting actually causes more pressure onto the stomach, leading to reflux. So the incidence, it increases between the age of 2 and 6 months in infants. And in about 85% of infants by 12 months, this often does resolve, and 95% by 18 months it resolves. But GERD incidence does increase in infants who are overfed or have chronic lung disease or are fed in a certain position, as I had stated before. And other common causes of gastroesophageal reflux in infants can be a milk allergy as well. So GERD in children, adolescents, and adults usually manifests itself pretty much the same throughout those age groups. And most children under 12 years of age and some adults actually don't exhibit any heartburn. They don't complain of heartburn. They may experience a dry cough or asthma symptoms or trouble swallowing foods. And they often, a lot of times, report foods irritating or aggravating their symptoms, even though there may not be any scientific data behind those foods actually causing the lower esophageal sphincter pressure gradient to drop. So foods, spicy foods or tomato-based foods or like oranges, lemons, acidic foods like that may aggravate their symptoms. So for the medical nutrition therapy for GERD, it's definitely an area that dietitians can have a lot of input in to help managing the symptoms of GERD. So the lifestyle components of treating this disease are really important. So it can help to address problems with esophageal pain or aphasia or confusion about certain foods that will trigger exacerbations or not, and then drug-nutrient interactions can definitely be addressed by a dietitian. So these foods or spices have been found to lower the lower esophageal sphincter pressure, and that is black and red pepper, coffee, caffeinated or decaffeinated, because there is a small amount of caffeine even in decaffeinated drinks. Alcohol, chocolate for its fat content as well as caffeine content. Mint, spearmint, or peppermint, or foods with high fat content. So the high fat content foods, it delays stomach emptying and can lead to aggravated symptoms of GERD by just staying in the stomach for longer. And other interventions that we want to try to make with our GERD patients would be encouraging them to have smaller, more frequent meals, possibly lose weight if they are overweight or obese, and helping them to think of ways to clear the materials from the esophagus, which would be kind of being more mindful when you're eating and slowing down, not eating too fast, and maybe taking small sips of drinks, not having large amounts of liquids while you're eating, but to kind of encourage them to make those kind of modifications. Remaining upright after eating, not going to bed after having eaten 3 hours or less beforehand, and wearing loose fitting clothing, and raising the head of the bed for sleeping. So these are some diagnostic procedures that help doctors to be able to diagnose. So most of the time it's done through an endoscopy and barium swallows. Those are the more common. So these are some treatments, medical and surgical There's antacids, buffering agents, histamine blocking agents, prokinetic, PPIs or proton pump inhibitors, mucosal protectants, and then as far as surgical procedures, there's the Nissen fundoplication where the stomach is wrapped around the lower esophageal sphincter, and that tightens the sphincter and not allowing the reflux to occur. The Stretta procedure, it utilizes radio frequency waves to strengthen the lower esophageal sphincters. So these are some reimbursable codes for diagnoses as registered dietitians that we can use for GERD. So my case study patient, she was an 86-year-old white female, and her height was 5'3", weight 173. Her usual body weight was around that, around 180. So she was obese, and just her past medical history includes some cardiovascular health issues and some GI things that are related to nutrition, and then of course GERD. There's no history of tobacco use, alcohol use, or illegal drug use. So in the medications that she was on in the hospital and even at home, she had been on a PPI, which is the pantoprazole, otherwise the brand name is Protonix, and then famotidine is Pepcid, and that is an H2 blocker or a histamine blocker. So both of those are used to help treat GERD. And so her socioeconomic history, she lives alone, but she has a lot of family support and input. And she planned to return home after discharge. And she's a retired teacher. There's really no cultural or religious preferences that would restrict any dietary needs. So the reason she was admitted to the hospital at Ohio Valley General Hospital was for left upper quadrant pain. And according to the patient, we interviewed her, and she said that her GERD had been managed well on her PPI, which was the Protonix. She follows a regular diet. She did report having a decreased appetite recently, and she feels full quickly, has occasional nausea, eats a lot of like TV dinners because she eats a lot of times by herself. She doesn't really have motivation to cook for herself at home. She drinks whole milk for the fat content of her milk. In the hospital, she was on the CCU diet, which is the critical care unit diet or a heart healthy diet. And but at home, she follows a regular diet. And then while in the hospital, the nursing staff wasn't really documenting her intake, but the patient reported that it was fair, so about equal or a little bit greater than 50% of her meals. So she had complained about left abdomen pain, her physiological and disease status post the EGD, which you really want me to try. It's like duodenoscopy.
Pretty cool.
Okay. So after that, they had determined that she had had chronic gastritis coming into the hospital. Her GI hemorrhage had stopped, and she had a small hiatal hernia, and then they were questioning a polyduodenal fistula. Her stomach pain was improving, and there was another CT scan scheduled. And then she also had some pulmonary hypertension issues. As far as her lab work goes, she was low with her potassium, which she had been having some diarrhea, which that could have been a cause of that. And then the other ones I wanted to embolden were her red blood cell count, her hemoglobin, hematocrit, and mean corpuscular hemoglobin levels, and those are all low, which would go hand in hand with the gastritis and the GI hemorrhaging, the blood loss, as well as the medications she was on, the PPI, which was the Protonix, and the H2 blocker, the Pepcid, would also decrease the iron absorption in the body because that decreases the acid production levels, not allowing as much iron to be absorbed from her diet. So she these labs indicate iron deficiency anemia. So the sample PES statement that I chose for her was undesirable food choices related to a lack of knowledge of foods triggering GERD, and as evidenced by frequent consumption of high-fat foods. She was consuming foods that were high in fat, mostly TV dinners, high in salt content, and as part of her nutrition education, the dietitian and I did ask her if she would be willing to change her whole milk to maybe 2% or even 1%, and then eventually maybe to skim, and she seemed open to that suggestion. And then we also explained trying to pay attention to the nutrition facts labels on the TV dinners to stay away from the high sodium or higher fat meals. And those are other potential nutrition diagnoses that can be used in a PES statement.
Can use more than one.
Yeah.
All of you are hung up on one.
On just one. So the nutrition intervention, you need to try to address improving lower esophageal sphincter competence, decreasing gastric acidity, and improving clearance of the contents from the esophagus, initiating weight loss, identification of the drug-nutrient interactions, especially the calcium, B12, and iron, preventions of obstructions or esophageal sphincters from trying to manage and not eating foods that will lower that lower esophageal sphincter pressure, and then improvement of overall nutritional intake. So in the monitoring and evaluation, you would obviously want to monitor their diet intake and their weight, but then the goals for the patient would be to try to make these dietary or lifestyle changes, even if it's a little bit at a time, to reduce gastric acidity and to raise that lower esophageal sphincter pressure and to try to increase its competence. And then they'll also want to lose weight if that's appropriate in the case of that patient. Does anybody have any questions?
What is Barrett's esophagus? You know?
Barrett's esophagus, it's where the cells in the esophagus begin to change from the constant exposure to the acid in the stomach. They start changing actually into cells very similar to the stomach itself. And that can, it's a precancerous condition, so from there, it can turn, those cells turn into cancerous cells and keep growing.
And you know, everybody, when they pay their bill at the station to go leave from a restaurant, they always pick up your type of a patties. They sit there and they look so good. Are those good for you? If you have GERD?
No, because they have mint in them, so
And
that's,
chocolate.
yeah, and chocolate, yes.
Normally does, but he's out in India this year for that's so he usually does my parents are this as a pastor. He came the last 2 or 3 years and had left to do like he heard of egg cooking. It's like a thing where you like boil eggs and and we've done it forever. My grandparents and just the kids. The head of 2 people what know like kind of battle. And then he was like, I don't know if you want to do it. And he was like, I don't know if you want to do it. And he was like, I don't know if you want to do it. And he was like, I don't know if you want to do it. And he was like, I don't know if you want to do it. And he was like, I don't know if you want to do it. And he was like, I don't know if you want to do it. And he was like, I don't know if you want to do it. And he was like, I don't know if you want to do it. And he was like, I don't know if you want to do it. And he was like, I don't know if you want to do it. And he was like, I don't know if you want to do it. And he was like, I don't know if you want to do it. And he was like, I don't know if you want to do it. And he was like, I don't know if you want to do it. And he was like, I don't know if you want to do it. And he was like, I don't know if you want to do it. And he was like, I don't know if you want to do it. And he was like, I don't know if you want to do it. And he was like, I don't know if you want to do it. And he was like, I don't know if you want to do it. And he was like, I don't know if you want to do it. And he was like, I don't know if you want to do it. And he was like, I don't know if you want to do it. And he was like, I don't know if you and I'll like tap the other egg. I'll try to like my butt and I'll like tap the other egg. So and like whatever egg like wins or doesn't get like broken, it's like the winner. We used to like 5 Easter eggs. I don't know more. It's probably
Mallory.
Okay. Thank you. There's a checkbook. You'll find the jobs out here, not in Maryland. Just meet under traffic gas. For a while.
All right, hello everyone. I know it's been a long day, but we're almost through it. My name is Lauren Arnett, and I'm going to be talking about CVA with dysphagia. And CVA is just an acronym for cerebrovascular accident, also known as a stroke. So looking at the pathophysiology, a stroke is when a blood vessel that carries oxygen and nutrients is either blocked by a clot or it bursts inside. And you'll get to see the couple different kinds in a few slides. This is when part of the brain is unable to receive those nutrients, and it actually causes the brain cells to die. And it's actually very important on which side of the brain is affected, especially for my patient. If you look at if the right brain is actually affected, that leads to vision problems, memory loss, and paralysis on the left side. And if there is a left brain clot or burst, then there can be speech and language problems as well as paralysis on the right side and also memory loss. And for my patient, it's actually on the left side of the brain. There's also the brainstem. If that part's affected, then a person can become in a locked state and they can't have any movement below the neck. So that's very severe. And then looking at the dysphagia side of things, as you can see, this could really affect speech and swallowing difficulties and the lack of coordination and pharyngeal muscular issues that can be caused by these clots. So here are the two different types of stroke. There's the ischemic stroke, which is the blood clot, as you can see it as it's traveling through there, and then the hemorrhagic stroke, which is actually when it bursts inside of the brain. The treatment, they are different for the different types of stroke. The treatment for the ischemic, for the clot, is to dissolve it or bypass it, and that's being done through a medication called tissue plasminogen activator. And then for the hemorrhagic, where it bursts, it's actually just to stop the bleeding in the brain and control high blood pressure. There's also a third type. It's kind of more of a category, not a separate type, and that's a transient ischemic, and that's a mini stroke. So that's kind of like the warning sign that it could be leading to something more. Looking at infancy, childhood, and adolescence, strokes are actually increasing in the younger population, and they think that that's because of the increasing rates of obesity, diabetes, and high blood pressure. Kind of a scary thought. Strokes can happen to anyone, and they can start at any time, including in babies, teens, children, and unborn babies. So, like I said, it's also a little bit because they are getting better at detecting this in the younger population, because before, even with the signs of mini seizures, as a child is born, they were going unrecognized because they weren't thinking that children could have strokes. And then these are some of the risk factors for strokes in children, and that's congenital heart defects, sickle cell disease, immune disorders, diseases of the arteries, abnormal blood clotting, head or neck trauma, and maternal history of infertility. So those are some risk factors. There's actually a fact that I found that 1 in 4,000 live births
That's how many are affected, and the risk of stroke from birth through age 18 is almost 11 in 100,000 children per year. And again, like I said, because people don't think of newborns as having a stroke, their signs can go unnoticed. But they do actually recover better than adults, so that's good. And like what I just talked about with the tissue plasminogen activator as a medication, that's very controversial in the younger population, and it's still being studied as a way to dissolve those clots for the younger population. So that could be something that might be used in the future. But the current treatments that are used are basically to manage intracranial pressure, antithrombotic therapy, control high blood pressure, and supportive care to maintain normal body temperature, hydration, and blood sugar levels. And the disability is kind of one of my main points just because of the dysphagia that we'll be talking about. Here's a nice slide on some stroke statistics. Looking at how we looked at ischemic and hemorrhagic strokes. Ischemic strokes are more common. They're in about 87% of people, so the clotting is more common. Stroke is the 4th leading cause of death, and it is the leading cause of disability. Every 4 minutes, 1 American dies from a stroke, so during my presentation, 4 Americans sadly could pass away from a stroke. And 49% of Americans have at least one risk factor, which I'm about to talk about. So some of the risk factors, a good thing is that 80% of people with a stroke, let me rephrase that. Approximately 80% of strokes can be prevented, so that's a really good thing. We want to try to make sure some of those, not predisposed factors, but the things that we can control. Some of the risk factors include diabetes and high blood pressure. High blood pressure is actually the leading cause. Smoking and obesity, obviously related to our diet. And MCA infarct, which is middle cerebral arterial infarction, and that's the lack of the blood flow to the brain. With age, it actually doubles for each decade of life after age 55, and like we talked about, it actually is increasing in the younger population, so we are looking more towards that. Heredity, race, and diet. So African Americans do have a higher risk for developing a stroke because they have higher risks of obesity, diabetes, and high blood pressure. And women have more strokes than men, and that can be because of the use of birth control, just the contraceptive measures, and also pregnancy and postmenopausal hormone therapy. Looking at the lab work, some important things to look at for stroke is glucose levels, but this can actually be confused with diabetes, or it can be mistaken for signs and symptoms of stroke when actually it's for diabetes, which is the risk factor for a stroke. So it is very important, along with electrolytes, blood lipid tests, which obviously we want to make sure that our fats and our cholesterols are in check, hemoglobin A1C, the complete blood cell counts, and prothrombin time, so how quickly our blood is clotting is very important. Dysphagia, looking at dysphagia, which is the difficulty swallowing. This can be one of the disabilities that occur after you have a stroke. And this can be just a sensation of food getting stuck in your throat, as well as physical signs of drooling, hoarse voice, regurgitation, frequent heartburn, and losing weight. But not always. You might not always have all of these signs and symptoms. There are different phases. On one of my handouts, I don't think it showed up very well, but there are different stages of the swallowing process. So it's very important when speech therapy is evaluating that they're looking at which part is the issue to see if in the future they can give them some tips and guidance in strengthening those muscles that aren't working properly so that they can upgrade in their diet and their textures. The main risk for dysphagia is aspiration, so we want to make sure that that's not getting into our lungs, and again, all of that is on the handout. This kind of shows it a little bit in the process of food moving through and how that can be messed up if those muscles are not working properly. MNT all depends on where the location and extent of brain damage occurs from the stroke. So like we talked about the right or left side, how severe it is, but for the most part dysphagia, most of us have heard of the different diets. So there's the stage 1, 2, and 3 where we have our pureed foods, our mechanical soft foods, there's also ground texture foods, and then we also have thickened liquids, so our nectar, thickened liquids, honey thick, and pudding thick. And just depending on where they're at in their stages and their swallowing. Their swallowing therapy, and that is actually where they can use exercises to coordinate swallowing muscles to re-stimulate the nerve, so you can gain back some of that control, and also techniques of where to place the food in your mouth to have a better outcome. Looking at just a heart-healthy diet because of stroke, so we want to make sure that we're on low sodium, lower fat content, increasing our whole grains, fruits and veggies, so just all of those normal things that we like to think of when we're educating on heart-healthy diets. Feeding tubes may need to be in place if they just have no ability to swallow any longer. And medications, again, are dependent on the stroke and what type it is, and the meds that they're going to use to either dissolve the clot or help with the high blood pressure. Here's the coding and reimbursement, and I kind of stayed directly to dysphagia with what type it was. So like I said, the different phases of dysphagia, and then also everything else that goes into it, the speech therapy, the evaluations. There's one for communication and auditory processing, physical therapy, and occupational therapy, which my patient was also using. There's the resources for that portion. So looking at my patient, we're going to start with a little bit of background first. This actually occurred in 1992, his stroke, right hemiparesis, which is the paralysis of his right side, and aphasia. He was a heavy alcohol and cigarette use before 1992, but then he stopped after that. He had bladder and prostate surgery, eye trauma as a child, and when he was admitted, he was actually admitted in 2001. He was skilled, but he was deteriorating. His functional status, he's using a lift, he has a diaper, total care and assistance for dressing, bathing, grooming, bladder program, and bowel program. So he has a lot of different programs going on, a lot of assistance needed. Looking at his medical history, as you can see, there's a lot going on with him, but if we refer back to the risk factors that we're directly looking at with stroke, obviously dysphagia is a result. Hypertension was one of our risk factors, one of our major ones. The venous stasis, that's a big one. Obesity, he's very overweight, and also diabetes. He does have diabetes. His socioeconomic history, he's a white, non-Hispanic origin Lutheran. He is divorced, but his sister comes in on occasion to be with him. He's English speaking, and he was a postal worker. He's not responsible for himself, which I already said, and he's an unemployed veteran. He's using Medicare, but he was very pleasant, and he was always smiling. He was always saying hello, but how much he wanted to. So, 2011, I correct myself. He is 84 years old. He's 5'11", 234 pounds, so his BMI is 32. His ideal body weight would be 172, so as you can see, he is way past that. Unfortunately, the lab values that I was able to see were just the bare minimum. They didn't really have good record of it. I would have liked to look at the hemoglobin A1C and a few other things with his lipid profile. The medications that he is on, and I have quoted the ones that are of the most importance and significance to us: albuterol for shortness of breath, sertraline for his depression, glipizide for his diabetes, prazosin, which is benign prostate hypertrophy, and simvastatin for his hyperlipidemia, and lastly warfarin for AFib. He is independent with a wheelchair. He has upper and lower extremity weakness, so they were trying to work on his strength and mobility. He does require a lift, and he speaks rarely. However, when I was reading the chart, it was almost like a completely different person when I went in there and talked to him, because he just seemed like it. In here, you just think of somebody just laying there and not saying much, but when you went in there, he was smiling and talking, and it must have been a good few days, but you could also tell when he wasn't having such good days. Incomplete bolus formation, that has to do with his dysphagia, and a few of the other patterns that go along with dysphagia. So currently he is in a fair state, but he is declining since his admission, and he has been losing weight, which we would like him to lose weight, but not in the way that he is because of his textured downgrade, and I'll go through what his diet is. He's on a limited simple sugar diet because of his diabetes, and high salt foods also to control blood glucose and low sodium. He complains that he hates thickened liquids, so he likes to sneak sweet teas, so he'll ask people in the hallway who don't know him to open up a sweet tea for him, and people would, and that would end poorly because he can't swallow it correctly, but he was very good at getting around that. Like I said, very pleasant and funny man. So going through his diet a little bit, I won't go completely through it, but at admission he was on a regular textured diet, then he downgraded to a mechanical soft because of his decrease in his ability to swallow. And then he went down again in 2014 to a ground nectar thick liquids with a magic cup because he had pressure ulcer. And now currently he is on a ground diet. So like I said in the bottom, he had a stage 2 pressure ulcer, but that has gotten better now. They were putting him on magic cups because, and that's just the high calorie, high protein, because he loves ice cream. So they'd been giving him 2 each day, but he started gaining weight from it. So we were trying to like wean him off of the ice cream, but let him enjoy it. So they were trying to maybe just prolong his life and maintain it. Like I just said, went over this, they were trying to keep him on 2 a day just because they really wanted to give him what he wanted, but we were trying to cut him back to 1 a day. So for his diagnosis, dysphagia related to CVA, as evidenced by his modified dysphagia diet and his history of choking. His second diagnosis, increased caloric intake related to food texture downgrade, as evidenced by his weight loss. And the third diagnosis, chronic kidney disease related to diabetes and hypertension, as evidenced by his medical history. So his current intervention that he's on, they're working with a speech therapist, a dietitian, and the nurses. He's on the ground dysphagia diet with thickened liquids. He uses curved spoons so that he can eat more easily. Also, there's a Dysum under his plate, again, so he can eat more easily and have the sides of the plates. He has a 2-handled cup and built-up utensils. Again, his medications and diet, we went over that, and his energy requirement that they currently have him on is a 2,000-calorie diet. The goals for him right now are to tolerate the least restrictive diet safely with no signs or symptoms of aspiration, because they've had to go back and forth. And those are just broken down by the liquids, the actual texture diet, and then tolerating trials of mechanical soft. So they're really trying to see if they can upgrade him a little bit. They're trying to get him to not aspirate, to increase his wheelchair positioning, and having him get up for 4 minutes of activity tolerance to increase his strength, which I talked about earlier. The monitoring and evaluation, they reassess him every 3 months, the dietitian, and the speech therapist also. They have a questionnaire on diet preferences, which I was a part of, and I know some of the interns were also a part of. Just figuring out what types of foods they like and what they're gonna eat if they have to eat it in a different lower form. There is a form on neurological and physical status and checking weight and blood pressure changes. Again, looking at all his different trainings that he's on, he's still doing the bowel and bladder trainings, the nursing services, occupational therapy, speech therapy. He's under close supervision, and unfortunately, he will reside in the facility. And these are my notes cited. Does anybody have any questions? Thank you.
I have one if I may. I don't know whether you came across this word, but did you come across anything called hemanopsia? Does anybody help her out? Well, start to think of teeny would be one. So the person, when they have their tray, if you see somebody who this food is totally untouched, and this is totally.
Because of his, isn't it because they only really see half the plate?
They already see the half of everything. So you have to teach them this. So if you ever see that, you want to say.
What is it called?
Hemanopsia.
Jessica doesn't.
Okay. Thank you. I like your nail color.
It's different.
I like it. It's nice and bright.
I'm not a bright person, but I love different.
Yeah, it's fun. It was like cultural food. Oh god. She went like she went really long.
All right, hello everyone. I'm Jordana, and I'm the last intern, so thank you for your patience. My formal case study topic is myocardial infarction, coronary artery bypass graft. So myocardial infarction is also abbreviated MI, and it's also known as a heart attack. It's when part of the heart is deprived of oxygen due to the blockage of a coronary artery. Every year, about 735,000 Americans have a heart attack. Of these, 525,000 have had their first heart attack, while 210,000 have had a heart attack in the past. The pathophysiology of a heart attack is an ischemic event where there's an increased need of oxygen or a decreased supply of oxygen available. This can occur within 10 seconds, and if it lasts longer than 20 minutes, it can cause irreversible damage to the cells and tissue. The causes of a heart attack are having one or more arteries blocked or a spasm of a coronary artery. The coronary arteries carry blood containing oxygen and other nutrients essential to the normal functioning of the heart. Partial occlusion or blockage occurs because of the gradual buildup of plaque rich in cholesterol. Coronary artery spasms are more common in people with the risk factors of heart disease, and coronary artery spasms may be triggered by tobacco use, exposure to cold, extreme emotional stress, and or the use of illegal stimulant drugs such as cocaine. This is an illustration showing the partial and complete occlusion, and this is an illustration showing the formation of plaque. These are some of the risk factors of a heart attack. They include age, tobacco use, high blood pressure, high blood cholesterol or triglyceride levels, diabetes, family history, lack of physical activity, obesity, stress, illegal drug use, autoimmune conditions, and specifically for females, history of preeclampsia. Some complications of myocardial infarction include stroke, cardiogenic shock, congestive heart failure, cardiac tamponade, arrhythmias, and pericarditis. Symptoms usually appear within 24 hours before the acute attack, but can begin 2 to 3 weeks prior. The duration varies from a few minutes to several hours. Some of the symptoms include chest pain, increased heart rate, difficult or labored breathing, excess sweating, nausea, and vomiting. Some nonspecific symptoms include weakness, fatigue, indigestion, dizziness, nervousness, neck, back, or jaw pain, along with pain going down the arms to the hands. So there are 6 different treatment options for a heart attack. There's immediate adjunctive treatment, which includes nitrates, beta blockers, calcium channel blockers, morphine, and oxygen. Antiplatelet therapy, which includes aspirin, clopidogrel, and glycoprotein inhibitors. Anticoagulant therapy, which includes unfractionated heparin or low molecule weight heparin. Fibroanalysis, which includes recombinant tissue type plasminogen activators. Primary percutaneous coronary intervention, which includes plain old balloon angioplasty, bare metal stents, and drug-eluting stents. And last is the surgical revascularization, which is the coronary artery bypass graft, also known as, with the abbreviation, CABG, and simply known as bypass surgery. The bypass surgery creates new routes around narrowed or blocked arteries, allowing sufficient blood flow to deliver oxygen and nutrients to the heart muscle. The bypass graft for CABG can be a vein from the leg or the inner chest wall, along with the radial artery from the wrist and the forearm. It is the most frequently performed cardiac surgery in the U.S. Before the surgery, you have an EKG, an angiogram, chest x-rays, and lab tests. During the procedure, you are put on a heart-lung machine, which stops the heart from beating while the surgeon sews the tiny arteries and veins together to form the grafts. The surgery usually takes 2 to 5 hours, and after the surgery, the patient goes to the ICU overnight for monitoring. The patient stays about 3 to 7 days in the cardiac care unit. There's only a 2% chance of dying from this procedure, and many people remain symptom-free as long as 10 to 15 years. And this is a picture showing the single, double, triple, and quadruple bypass. So it is important to remember this acronym MONA because 1/4 of all heart attack victims die before reaching the hospital. Individuals that have had recent heart problems will typically have nitroglycerine at their home, but almost all Americans will have aspirin available. The condition is very rare in children and adolescents. It's more common in adults due to the gradual buildup of plaque. Some lifestyle changes are to incorporate more plant-based foods, avoid excess sugar, saturated and trans fat, sodium, and processed foods. Be mindful of how much you're eating, so the portion sizes, avoid smoking, control your blood pressure and cholesterol levels, get regular medical checkups, exercise regularly, specifically 30 minutes per day, maintain a healthy weight, eat a heart-healthy diet, manage diabetes if you have, control your stress, drink in moderation, and sleep at least 7 hours per day. It is important maintaining a healthy blood pressure for keeping your heart healthy. Sodium in our diets may affect our blood pressure, and when we eat too much of it, we retain fluids, making our heart work harder to pump blood through our system. The heart-healthy diet, you'd want to try to incorporate whole grains, vegetables and fruits of variety and colorful choices, low-fat dairy, lean proteins, use vegetable oils and the healthier fats, try to include nuts, seeds, and legumes, and try to have less than 5 sweets per week. This is a table illustrating the nutrients and how they affect our health along with the food sources they are in. The unsaturated fat, they lower our blood pressure, they lower the LDL, improve our HDL, and reduce the risk of heart disease. These include monounsaturated and polyunsaturated. For example, avocados, seeds, walnuts, olive oil, and fish. Saturated fat increase the LDL, increase the risk of our heart disease. These food sources include butter, bacon, sausage, and other animal fats. Trans fat will increase the LDL while lowering your HDL, which will increase the risk of heart disease. And these include partially hydrogenated oils, shortening, fried foods, etc. Your body produces some cholesterol on its own, but you can take control of your LDL and HDL levels by choosing nutritious foods that keep your arteries clear. Eating foods high in cholesterol does not have a huge impact on your LDL levels. Blood cholesterol is largely affected by the type of fats you eat. A balanced diet is key and not limiting all fat. Some tips for a heart-healthy plant-based diet include going for the greens, incorporating vegetables for half of the sheet, eating a fresh fruit opposed to having a baked good for dessert, and trying to make a vegetarian meal 1 time per week. For the Mediterranean diet, it's important to incorporate more herbs and spices opposed to using salt, and eating more fish and trying to limit your red meat intake. These are the codes and reimbursement for the heart attack. And then my case study patient, I nicknamed him Mr. Heart. His medical history, he has type 2 diabetes, chronic kidney disease, hypertension, he had his gallbladder removed, coronary artery disease, and he had stents at 75 years old, and he had his first heart attack at 71. So his chronic disease risk, he is 81 years old, he was a former smoker, he has hypertension, obesity, diabetes, and his father has heart disease. These are all of his oral medications, which comprise of blood thinners, acid reflux medications, blood pressure, diuretics, insulin, laxatives, pain relievers, and vitamin C and iron. His IV drip medications include antiarrhythmic, fluid nutrient and electrolyte replenishers, vasodilators, pain relievers, and prevention of nausea and vomiting. For his biochemical measurements, these are all of his lab values that were abnormal, and they're indicative of retaining water, chronic kidney disease, anemia, excess acetaminophen, bleeding, diabetic ketoacidosis, calcium, magnesium, or vitamin D deficiency, along with malnutrition. So his social and economic history, he's in good mental and emotional status. He is currently retired and only collecting Social Security. He's white, Catholic, and Italian, and his wife shops and prepares all foods. And he tries to walk 3 times per week at the YMCA. His anthropometric measurements, he is 5'8", he weighs 213 pounds, his BMI is 32.79, and his weight status is currently obese, and it may be associated with health problems in some elderly. His ideal body weight is 70 kilograms, and his adjusted weight is 80 kilograms. His usual body weight per patient was 82 kilograms. For the calculations, I used his adjusted weight due to his BMI being over 30. For his caloric needs, I found 2,000 to 24,000 calories per day. For his protein, it was 80 to 120 grams per day. And for his fluid needs, about 2,000 milliliters per day. For his diet history at home, he was on a regular diet and he lived a healthy and active lifestyle. At the hospital, he was placed on a consistent carbohydrate. And at the hospital, they further adjusted to level 3 dysphagia. For his nutrition assessment, he had no pressure wounds, he had +1 generalized edema, and they discontinued the fluids due to his edema. He had his CABG procedure on the 16th. He had his last bowel movement was on the 14th, which was prior to admissions. He was NPO before and after the procedure, and his intake was very poor. On the 18th, he had an average of 20% intake for 2 meals, and on the 19th and 20th, he had an average of 27% intake for 3 meals. According to the electronic medical record, the patient had gained weight since admission. So please note questionable accuracy on weights due to large variation. On the 15th, he was 184 pounds, while on the 20th, he was 213 pounds. And this can be due to his chronic disease of kidney and also his edema. For his PES statement, I wrote inadequate PO intake related to surgery with decreased intake and loss of appetite, as evidenced by poor intake with less than 50% intake at each meal. For his nutrition intervention, I want to monitor weight status in labs, continue to follow for changes in the weights and hydration, change the diet reflecting the speech pathologist to the level 3 dysphagia, provide no sugar added Mighty Shakes 3 times per day with meals, and per consult request I provided heart healthy information. For nutrition monitoring and evaluation, meal completion of greater than 50% for 3 meals daily, and intake of the Mighty Shakes greater than 50% 3 times daily. And also for his bowel movements to return to normal before the patient is discharged. During my follow-up, his intake had significantly increased. He was intaking about 74% per 8 meals. He had +1 edema in his right lower extremities and then +2 edema in his lower left extremities, specifically his ankle. And he did have a bowel movement on the 23rd prior to his discharge. His weight went down a little bit to 203 pounds. And for his new PS statement, I wrote biting and chewing difficulty related to dentures not fitting correctly and causing pain in gums, as evidenced by a change in diet to texture-modified meats ground only. So the plan was to monitor and encourage PO intake, monitor the weight status in labs, recommend to continue the nutrition supplement, and then monitor intake with new change of diet. The goal was to have a meal completion of greater than 75% for 3 meals daily, and to intake the Mighty Shakes greater than 50% 3 times daily. Does anybody have any questions?
Is everybody now on the heart-lung machine whenever they have surgery? bypass surgery?
You don't necessarily need to be, but it is more often than not.
But we're getting to do less and less now than we used to. It used to be, you have the surgery, you're gonna be in the heart long.